So now I'd like to welcome Michael Toal from Northern Ireland. Can you turn failure into success?
Thank you. Hello, thanks for inviting me to speak today. So my name is Michael Toal. I'm a CT1 trainee in Northern Ireland at Belfast City Hospital. And my project was based on looking at BNP measurements. So as an introduction, the N-terminal pro-BNP is released from the left ventricle in response to strain and heart failure. It's quite an expensive blood test. It costs over £16. By reference, a urea and electrolytes test cost around £5. And over a 2-month period, we spent over 850, or just short of £850 from the ambulatory cardiology unit alone. And from the whole hospital in that same period was over £10,000 doing these tests. Of note, there is no emergency department in this hospital. So this is a nice guideline from 2003 of diagnosis of heart failure. You can see at the top, if clinical suspicion is there, then investigations should be performed, including a 12-lead ECG and a BNP, where it comes in here. Should these be abnormal, they then can proceed to echocardiogram for a more definitive diagnosis. There's lots of causes for false negatives in BNP. Other cardiac problems, pulmonary disease, renal disease, liver cirrhosis, many other conditions can put a BNP up falsely. So our aim was to reduce inappropriate BNP testing by a target of 25% over a period of 1 year. And how we aimed to do that was educate staff, put visual aids in the ward for easy reference point, and to involve our lab staff as well, so that we're all working off the same page. So why do we think this is happening? Patients are attending for management of their chronic heart failure or another chronic cardiac condition. They're getting blood tests sent as part of their workup, and as part of that, BNP is being sent inappropriately. So what's driving this? Could be just added on. If they're getting bloods anyway, maybe someone just adds a BNP on as well. Maybe it's accepted practice. Maybe the consultant asked for it. Maybe well-meaning clinicians are looking to see, has their heart failure progressed? Or have they responded to their treatment? And there's no clear clinical indication that BNP is effective of showing whether this is the case, and it could lead to patients getting inappropriate treatment. So baseline measurements, what we want to know. We want to know how many tests were deemed to be inappropriate and how much money was being spent on these. So we looked over a 2-month period through the Northern Ireland Electronic Care Record of all the BNP tests being sent from this unit. There's 51, and we got figures from biochemistry. This is a very quick diagnosis to show the range of cardiac conditions that were already diagnosed when people attended. And I want to draw your attention to these 2 rare cardiac conditions, pulmonary hypertension and amyloidosis, where there actually is an indication for serial BNP measurements in response to treatment. However, for the broader population of heart failure, there is no role for this. So you can see that out of 51 tests, 16 of them were not used to aid a diagnosis of heart failure. So overall, a third weren't used for a diagnostic purpose. So around 30% were inappropriate, and that adds up in cost, over £200 from the ACU. And if the same percentage was applied to Belfast City Hospital, it's nearly £3,000 that was used inappropriately. So what changes did we do? First of all, we had to look at the guidelines. So these are the European Society of Cardiology guidelines for 2012 on heart failure. And you can see that several randomized control trials were looked at peptide-guided treatment and to see whether this had an outcome. And the results were conflicting. So using this approach is not evidence-based. We had to determine what was appropriate and what was inappropriate use of BNP. So you can see appropriate use is a clinically suspicious history, as a ruling out diagnosis, has a strong negative predictive value, deciding who to perform an echocardiogram on, and for initial prognostic stratification, with a higher BNP being associated with a less favourable outcome. So inappropriate use would be to assess progression of disease, to assess response to treatment, or if the clinical picture was not in keeping with heart failure. We had a training session for staff. That occurred in April, and junior medical staff, senior medical staff, and specialist nurses were in attendance. We put visual aids on the ward for staff, which are the 2 slides you saw before, and that was put in the control centre in ACU for easy reference. And we involved our lab staff as well, so they could be empowered to challenge inappropriate referrals that they received. So a second cycle took place after the teaching session took place over a similar 2-month period. And you can see that the total tests were reduced dramatically from 51 to 24 over a similar 2-month period. and inappropriate tests reduced from 16 to 7. That's nearly 53% reduction in total tests and over 56% in inappropriate tests, saving the Trust nearly £450 in total, and £150 was saved from inappropriate tests. And also importantly, it meant the patient was being given the relevant treatment rather than a blood test being treated. Limitations to this: we only had access to information available on ECR. There was only a small number of patients from one unit analysed, and determine what was appropriate and inappropriate was done by my assessment of what was available from the discharge letter and based on the guidelines. The next step is the ongoing support of the message. If BNP isn't required, don't send it. I'll soon be presenting to the biochemistry staff in the Belfast Trust, so again that our ward staff and our lab staff are all on board. And we'll see if change is sustained after we change placement in August. So the question I asked initially is, can you turn failure into success? How is the best way to treat our patients with heart failure? It's not with BNP measurements. The role of an experienced clinician and their clinical assessment remains key. To treat the patient, not the blood test. Happy to take any questions. Thank you.
So what do you think is going to happen in July?
Well, if I'm not there to hammer on people about sending BNPs, hopefully they won't go up. But I think the change has been integrated within the unit itself, so the consultant specialist nurses, as well as junior medical staff, are involved. Only the junior medical staff will be moving on, so I'm hoping the message will be sustained, and visual aids will certainly be sustained, that we'll maybe think before we send blood tests more often.
And do you think the laboratory staff have been empowered to challenge?
I think that's our intention, and certainly I've been involved. The inappropriate and appropriate slides have been sent to consultant biochemist, and I'll soon be presenting to a wider biochemistry staff in order to empower them to challenge inappropriate tests, because the figures I was presenting are only the tip of the iceberg, really, in terms of how much money's been wasted on it. In one hospital, near £3,000 over 2 months, so across the UK it's bound to be many thousands.
And what about primary care? Because there is something about the number of those sort of blood tests that are done by primary care, which don't seem to influence the management of the patient. Yeah,
I think part of the aim was to educate people that BNP measurements are not intended to be used for serial measurements. So if somebody has heart failure and they have an echocardiogram that confirms heart failure, there's no requirement to repeat BNP testing to see that increasing diuretic help. You have to assess them clinically, and that remains the gold standard.
Okay.
Okay.
Thank you very much.
Thank you very much. Thank you.